know, it's super awkward. Okay. All right, you guys ready for our jokes?
Yes.
Okay. Where do crayons go on vacation?
The wax museum.
Nicely done. The wax museum. Wow. Ding, 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 ding. You have won the ground prize.
No, it was on the documentary last lecture and I watched that again today.
Oh, it was?
And you used it.
I already used it? Oh, look at that. I'm not even that funny. Like, I recycle my jokes. You all laughed it down, though. Oh, man. That's great. I got to shuffle the deck is what I need to do, right? Because I'm probably at about the same pace.
Well, last week you used the same one on the cheat.
Oh, was it on there?
No, you used that one this
All
time.
right, fine. Watch this. Pick a joke. There it is. We'll show you. Who earns a living driving people away? Find that on YouTube. Who earns a living driving people away? Nice job, a taxi driver. All right. Now that's funny right there. Look at that. You guys are on to me. Look at that. That makes it even better. You know, it's like it's the same class every year. These 320 jokes never change. Yeah, because they're sitting right there. All right. So our last little segment on the skeletal system. So today's actually going to be fairly clinical in nature. We're going to kind of wrap up this segment on the skeletal system. And I know that most of you are taking lab. How many of you are taking lab at the same time? Okay, so most everybody. And we always get these questions in 201. We get them more in 202. Is, how come lab and lecture don't actually follow the exact same schedule? Well, they really can't. They're two separate classes, number one. And number two, the focus is very different. I mean, lab, the focus is really on identifying the structure, telling where it is, and talking about a function. What does it do? And that's pretty much the whole class. ID, location, function. And it's like rote memorization. And in lecture, it's less about where stuff is or what the identification is. It's more about the function and actually how the function works. So that's where the physiology emphasis comes in. Whereas the lab is really emphasized on the anatomical portion. So for example, you are now finishing brain dissections last week in lab. And this week you're starting with muscle, right? You're talking about muscles of the back and the trunk, arm, shoulder, forearm, right? And hopefully what your lab instructor is going to sort of preface this whole week in lab with is you just came out of the skeletal system and the framework is important for muscle function. In fact, you also covered in lab already joints, right? And so you look at the bony architecture, and then there's a joint, and then muscles cross a joint, and muscles contract. And as they contract across the joint, that causes movement. If muscle contracts and there's no moving joint, you get no movement. Okay, so the architecture completely drives the functionality. So in our last little segment of the skeletal system for this exam on Thursday, we're going to kind of talk a little bit about more of the functionality of how the bone works and when things go wrong, when we break bones. Okay, we're going to talk about different types of fractures. We're going to talk about how the bone heals itself. All of you, how many of you had a broken bone? Okay, so we all know that the bones heal, and they heal quite well. In contrast, there are tissues that do not heal well. Shout out a couple of examples of tissues that don't heal well. Cartilage. What else? Nerves. Okay, what else? Ligaments, even tendons. Cartilage on that list is probably the one that heals the least, or the most incomplete, because it's the least vascularized. Whereas bone and muscle heal very, very well because they're extremely well vascularized. We're also going to talk about diseases like osteoporosis and bone health as we wrap up today's lecture. So before I move into that, our transition slide, our segue, is a question that you're very likely going to see in some format on Thursday. Okay, if you didn't catch that, because you're shopping on eBay, you probably want to pay attention right now. I just gave you a huge hint about a possible TQ on Thursday. So there are zones within the epiphyseal plate. Put them in order. Put them in order from the diaphysis to the epiphysis. The diaphysis to the epiphysis. Yeah, you can take pictures of the screen. There's no problem. Okay, but you have these slides. I mean, they're on BB Learn already. Okay? If you want my hand pointing at it while you're taking a picture, here you go. Ready? Go. All right. So, can you put this in order? Ready? Go. Diaphysis to the epiphysis. Starting from sort of the point of the epiphyseal plate that's located closer to the diaphysis and then moving towards the epiphysis. Right? So what side? You have to figure out what side you're at. If you're on the diaphysis side, what's happening at that location? What's happening on the diaphysis side of the plate? You get what? Bone calcification, right? On the diaphysis side. Okay, so bone calcification would be what? Zone of calcification. So it would start with 1. Right? So it's going to be A, B, or E. This is a practice on test-taking strategies. So you've just eliminated C and D because you're saying it doesn't start with zone of resting cartilage. Aha! But if you flip the orientation, you might have picked C or D because you would have thought you're starting with resting cartilage. But are you starting with bone? Yes. And then you end with what? Resting cartilage. So if you've got A, B, and E to choose from, and you know it begins with 1 and it ends with 2, what can you eliminate? A. Nicely done. So B and E are the only options that you have left. You could just flip the coin at this point and move on to the next question. Or you could keep reading, right? But you've already eliminated now your 50%, 50-50, right? So from resting cartilage, then where does it go? We're going backwards if you haven't figured this out, right? You're like, oh, yes. We're going backwards. We're going backwards from where bones lay down. We're ending on resting cartilage. So just before the bone lays down, where are we? Zone of proliferation. Nicely done. So that's 3. So now between B and E, you know that E is the correct answer. And obviously, the last one we already said, zone of resting cartilage. So if I ask the question in the reverse direction, it would be the same question. It would say, arrange them in the order from the epiphysis side towards the diaphysis. You with me? And then it would be backwards. Okay, so next possible question. Which direction is the epiphysis moving? Is it moving towards A, B, C, or D? So is it, which ones can you eliminate and why? A and D. Why do you eliminate A and D? Because it's the wrong direction, Keller, okay? Because we're smart. You can't fool us. Yeah, that's absolutely correct because the orientation, it's cartilage on the right and it's bone on the left, correct? And where does the bone lay down? The bone lays down over here on the left, correct? So the epiphysis, the end of it, is moving in the B direction. Okay? There was a question over here.
Yeah, on the previous question, what about the deposition zone? Is that just like not...
I just skipped it for this question. It's there.
Okay.
Yeah, I just skipped it. I left it out. I didn't want to make it that difficult, so instead of 5 zones, I only listed 4. Okay, good question. Okay, so if you're thoroughly confused, I would go to SI and ask the questions on, all right, do I really understand what's happening at the growth plate? Right in the middle of the growth plate, there's zones 1 through 5 that go from the diaphysis towards the epiphysis, and there's zones 1 through 5 that go from the epiphysis towards the diaphysis at the proximal end. And at the distal end, it's the same thing. Does that make sense? So you add bone on both sides of the plate. So one direction is 1 through 5, and in the other direction, 1 through 5 goes the opposite direction. Okay? So make sure that you understand the question, and you need to know the orientation of the plate. All right, so we talked about bone development in utero. We talked about when endochondral, and that word endochondral, some students need a trick on how do I remember intramembranous versus endochondral. Endochondral actually has the word cartilage in it. Within a cartilage model, that's what endochondral literally translates to. Endo meaning within or inside. Chondral is for chondrocyte, that's what makes cartilage. So endochondral is the cartilage model where you use the plates, right, during puberty that we just talked about, and you're getting elongation or interstitial growth after fetal development up until 18 in women and 21 in men, plus or minus a couple of years. After the plates close, then we talked about appositional growth. Appositional growth is where osteoclasts and osteoblasts dominate, and the blasts lay down new bone, and the class kind of chew up the old bone. And at the very end of the last lecture, we talked about the physiologic significance of why you would chew up bone and liberate what important ion? Calcium. Want to bet there's going to be a question on calcium homeostasis and one of those negative feedback loops that we talked about at the very end of last Thursday? Yes, there will be. So I would study that last figure. Now, after bone is done being formed, we have normal remodeling that takes place, appositional growth, osteoclast and osteoblast. But every so often, you trip and fall and you make a fracture. And we classify these fractures based upon different categories, right? And so some of them are listed here. So a closed fracture is one where it doesn't break through the skin. The bone fractures, it's clean. You might have slight hematoma or bleeding underneath the skin because the bone is vascularized. If you break the bone, likely you fracture a blood vessel. That blood kind of permeates up to the skin. A compound fracture is one that protrudes through the skin. It's also referred to as an open or displaced fracture. Those are the ones that are a little gory. Okay, the bone sticking through the skin. That's a compound, an open, or a displaced fracture. A spiral fracture, like one down here, a spiral fracture is usually a twisting type of fracture. Very commonly found in sports because of the complex motion that's taking place. A greenstick fracture. A greenstick fracture up here is one that's a twist, but it doesn't completely break. And it's usually found in children where the bones aren't completely ossified. Right? Like, it's almost like trying to snap a branch from a tree, but the branch isn't completely dried out yet. It's still green. And so you can kind of twist it and fragment it, but it doesn't really snap like a twig that's laying on the ground. Commuted. A commuted fracture, the commuted one right here, this one is actually one that fragments. It's very common in elderly patients because you have bone density loss that takes place as we get older, in both men and women. We'll talk more about that today. But this commuted fracture is one where the bone itself is very weak. And so as it breaks, it's not necessarily a clean fracture. It kind of fragments out. And there's a number of other ones. These are the ones that I really want to cover, the ones that I highlighted on that slide. So the other pictures, you can look at them, but they're not necessarily ones that I maybe ask test questions about. So if we fracture a bone, how do we treat it? Well, there's a couple of different methods or strategies. We can do it with what we call closed reduction, or we can do it with open reduction. Closed reduction means that you manipulate and set the bone, so to speak, but you don't need to open up the limb. You don't have any surgery that's necessary. An open reduction is one where there's surgical exposure, and an open reduction is where you're typically going to be using some sort of additional stabilizing device that needs to be implanted, like a screw, a plate, a rod, etc. And you can see some examples here of this fracture. It's a closed fracture. It's not an open fracture, but it's an open reduction where some plates and hardware is actually put in place in order to stabilize the limb. In both of these types of procedures, whether it's closed or open, you likely will use some sort of immobilization, whether it's a sling or a cast, or even traction in some cases, to move the bone into the location that you want it in. As the bone repairs, it is very, very similar to the processes of wound healing that we find in the skin. So this is kind of an interesting parallel. Is we spent some energy talking about skin wound healing, and you looked at some sort of gory pictures about wounds that take place at the level of the skin, which is a rather vascularized tissue as long as you go below the epidermis. The dermis itself is extremely vascularized. And the bone is vascularized, so skin heals pretty quickly, so does bone. And the process is rather similar in parallel to skin wound healing. So for example, you're going to end up over here, you're going to end up with a scar. You're going to end up with a fibrotic scar that's laid down. But let's back up as we look at the different steps. So the first thing that happens is you get this hematoma. That hematoma is blood outside of the vasculature that brings in new cellular elements. It brings in new nutritional flow. It allows for blood supply to be in the area where the healing needs to take place. Then you develop this soft callus. The soft callus is made up mostly of fibrocartilage. And so just like what we saw in developmental bone processes, we see in healing of bone, where the cartilage forms a scaffold, and then the granulation tissue that comes in as a result of the blood, that converts it into a soft callus, a soft type of scar. Eventually, the soft callus actually hardens, it ossifies. Osteoblasts move in, and they push out the cartilage and lay down a bony matrix. That's what osteoblasts do. And it forms a temporary bone collar around this hard callus that's converted from the soft callus. You can kind of see the squiggly red lines indicating new blood vessels coming in to bring in nutrition and remove waste products while this is happening. Once the hard callus forms and ossifies, you eventually will sort of, with osteoclastic activity, you'll hollow out the inside again. You'll shape the bone. It might be slightly thicker in that area where the fracture was, and it's very uncommon for it to break again in the same spot. And some of you might say, oh, I broke my arm twice in the same location. If you looked at it really carefully, you might have broken it more on the collar versus right across the same spot. And even if this is maybe a millimeter or two away, it may feel and appear to be in the same location. But in reality, it's probably on one of the thinner portions of that hard callus collar. Because right here, and I'll show you some radiographs that kind of prove this, you can kind of appreciate even months later, years later, where that actual thicker piece of bone is, where it was repaired. So this process is very, very similar to what we see in skin. Now in skin, we don't put down a cartilage model, right? But we lay down a scar. We lay down collagen instead of cartilage. And so we're using collagen in skin, and in bone we're using cartilage, but it's really trying to achieve some of the same things. Hey Patty, I'm going to have a couple of radiographs or x-rays in just a couple of slides. It'll be easier if we could dim them. Awesome, thanks. All right, so if we look at different types of fractures, many of you are PT bound. Okay, some of you are orthopedic surgeons to be. We classify our epiphysial fractures into some unique classifications if the fracture happens at a location that involves a growth plate. So some of you have had experience with this where you were younger and your growth plate was still in place. It's very common in toddlers, so they're extremely active, right? So everywhere in our house about from this high down is extremely scuffed up. Okay? Everything from this above looks pristine. Okay? Because I've got 4 kids and you know, they just tear through the hallways with, you know, scooters and, you know, you name it, it happens. Well, they trip and they fall, and what do? They put their hands out and catch themselves, right? And so a very common location to fracture the arms is the wrist in kids. And we call these Salter-Harris fractures. And you can kind of appreciate there's 5 different classifications, and this squiggly gap right here is this epiphyseal plate. And so you can see a type 1 is where the epiphysis is involved, and it's displaced. It's displaced over here to the lateral aspect, or to your right. In this situation, in a type 2, it involves the diaphysis at some level. So a type 2 fracture is the epiphysis is involved as well as a portion of the diaphysis. In a type 3, it's not displaced, it's actually cracked. And then in a type 4, it's cracked all the way through. And then a type 5 is more of like a compression where it comes together like such. In all 5 of these Salter-Harris-like fractures, what is the concern? What would you have? Knowing what you know, if you had a patient that was, say, 10 years of age and fractured their wrist, and you knew it was a Salter-Harris type 4, what are some of the things that you're thinking about immediately in your head? Will it stunt their growth? Or did it damage the lateral aspect, not the medial aspect, and now will the bone grow in sort of a twisted type of fashion? Okay? So these are some of the things that you'll hear about as you move on in your career. Patty, here's where I've got some radiographs. So here's an example of a type 2. Okay, so you can kind of appreciate this type 2 right here. And you can see the fracture also on this side, but this is where it's really classified as your type 2. So we'll back up. Here's our type 2. Make sense? If we go to the next one, this is down in the ankle location, and this one's actually a type 4. And the reason you know it's a type 4 is it's involving diaphysis, and then the epiphyseal end is actually shifted. Okay? And you got a crack right down there of the epiphyseal end right there. You see that little black, dark line coming down right where my laser pointer is if I move it away? In that whiter region. So that's a classic type 4. So on the exam, am I going to throw up an x-ray and have you play doctor and try to... No. I just want you to be familiar with the different types of Salter-Harris fractures. So when you hear it in PT school or in med school, it's not foreign to you. But I'm not going to put it wouldn't be really that fair if you interpret radiographs in a 200 level class. Okay? You're not going to find these in your textbook because this is kind of beyond what we talk about. But it tells a really good story as far as completeness for what we're talking about. Here's an example of a spiral type of fracture. Can you appreciate where it starts up here and where it ends down here and kind of spirals around? This is a skiing accident. Okay? Spiral type of fracture. Sometimes with these spiral fractures, we'll actually use fixator devices. So this device is implanted to the bone, and the appliance sticks out of the patient's bone, obviously, and skin. And so what can take place is they can take a radiograph of the bone, and if it's not set in the right location anymore, they can make adjustments, okay, on the spot. So this is a fixator type of device. While this is healing, we can have the lights back up. Thanks, Patty. While this is healing, actually leave them off for now because I got one more radiograph after this. Sorry. It's a light show. It's like, could you turn on the disco ball next? Just kidding. So the moment of inertia is maintained as we heal the bone. So what's pretty crazy about this is you have a hollowed out bone, you fracture it, you heal it, and after it's done healing, you carve out the intermedullary space again. Why would you do that? Why would you hollow out the bone again?
Give it more strength.
Make it stronger, based upon moment of inertia. What else? You can put marrow back in that space. Okay, what else?
If you didn't hollow it out, it would create an axis or a point where it could easily break those around.
You would create a weaker spot if you didn't hollow it out, because everywhere around it is going to be strong based upon moment of inertia, and that non-hollowed out component is going to be the place where it would likely break again. I just got done telling you, it usually doesn't break in the same spot. Okay? Very good. So as we think about this healing process we just talked about, what I want you to appreciate is that at the very end, you hollow out this to maintain this polar meaning sided, moment of inertia. You don't have a solid structure of bone that you regenerate. And it's kind of counterintuitive if you don't remember and don't understand how the relationship between mass exists as you push the mass further away from the central axis, or further away from the middle of the bone. More of the mass is sitting, then you actually have a stronger bone. Okay? So this moment of inertia is maintained as we heal our bone. And this is sort of the last radiograph in this particular segment of the lecture. This is actually showing from a different textbook, again, not your textbook. This is a femoral fracture, and here you have an intermedullary rod, or an intermedullary nail. That's what this is right here, running right down the medullary cavity. Okay, open or closed reduction to get that there? Open. I mean, you got to be like a Jedi Knight to get in there without cutting the thing open. Okay, and then here, 9 months later, where did the rod or the nail go? It's been removed. It didn't like resort, just so you know. It was removed. And then what do you see right here? That's the scar. This is the location. You see how much thicker this bone is? Here is that site of fracture right through here. And 9 months later, you can still see how much thicker that bone is as it's healed. Now, we already talked about moment of inertia, and the point of removing the rod is the same answer that we already went over. You remove the rod so that you can strengthen the bone longer term, that you can have the medullary space for bone marrow to exist.
How do those calluses work? Is that like arthritis or anything like that?
This right here, these calluses?
Yeah.
No. It has nothing to do with arthritis. So the callus itself is basically a word for a scar on the bone. So it's just the cartilage is coming in, laying down a template, and then the osteoblasts come in and lay down a bone matrix. And as they lay down new matrix, it looks a little different than the matrix that it started with. And so you, just like with your skin, you see a scar on the skin. That's where that callus is. It's a bone scar. Okay?
What would happen if the rod wasn't in there?
Well, so in some cases, the rod will stay in there for a period of time. I mean, physiologically, scientifically, the answer is it's better if it's not there. But a lot of physicians will say, you know what, there's lots of medullary space throughout the body. And as you move into adulthood, you don't even use most of your medullary space. You only use like the proximal end of the femoral shaft. And you use a little bit up here. But the main part of your long bones, once you're an adult, you don't need that much hematopoietic tissue anymore. It's more important for children. Because children, remember, the hematopoietic red bone marrow is found in every open space in children. But by the time you're this age, you probably don't need it much anymore. So if they're worried about the strength long term, okay, they may decide to keep it in there.
How do they get the pin out afterwards?
What's that? How do they get the pin out afterwards?
Try the intermedullary space.
Yeah, they pull it out.
Do they like bore another hole in your bone?
So a lot of times they'll have an exit site, and the site that they put it into with basically a mallet, and they'll put a tapping device, hammer it through, and pull it out the other end. Yeah. Orthopedic surgeons like have tool belts and, you know, plumber's crack and everything, dude. I mean, right? Now, one of my good friends is an orthopedic surgeon, so if he watches this, you know, it's like, that was for you, Bill. All right. Yeah, they pull it out. They pull it out just the way it came in. Or the opposite direction if it's coming out the back way. Okay? Okay. So that's how bone heals. We can put the lights back up, so I see like half the class, you know, sawing logs here. So diseases of bone. Now we're not going to cover every single disease of bone. In fact, we're going to cover very few. We're going to cover one in great detail, and that's osteoporosis, because it's the one that we're most likely going to come in contact with in your patients and in your family and your loved ones. You're going to see bone density. This is dead bone where the cells have been removed. And it gives you an appreciation for the architectural pattern of the bone. And you can see next to it is an image of osteoporotic bone, where the bone mass itself and the density has been compromised. Now, the challenge is it affects cancellous tissue or bone tissue all over the body. It doesn't just focus at the hip, at the femoral head. What you hear about osteoporotic-related fractures being very common in elderly patients when they fall and they break their hip. But if you think about it, when kids put their hands out, right? Elderly people, a lot of times, they just sort of roll with the fall. And as we get older, our weight distribution becomes more centralized. So we carry more weight in this area. And so the first thing that hits the ground is usually your butt, okay? Or the side of your butt. And that can lead to that fracture point. They're less likely to put their hands out. You know what? I'm too old for this. Just, here we go. Okay? So it's not surprising that you get these femoral head fractures. But if they put their hand out, they may have a clavicular fracture, right? You know, if they put their hand out, they may fracture arm bone, whether it's a radius, an ulna, or the humerus. So these fractures don't just happen at the femoral head. It's just because of the weight distribution and the imbalance as we get older, we lose a little bit of our ability to have sure footing. And what usually hits the ground first is your side or your butt. Okay? It's more common in elderly women than it is in men. And we're going to see the reason for that is based upon menopause. Post-menopause. Menopause is that period in a woman's life when the menstrual cycle stops. And as soon as the menstrual monthly cycle stops, the relative amount of estrogen basically plummets. And estrogen, as a sex hormone in women, has a tremendous bone-protecting capability. So estrogen promotes bone formation. It promotes osteoblastic activity. And when women lose that estrogen level, they're at huge risk for accelerated bone loss. And I'll show you some of the data as a result of it. So you can see, you know, the posture of this woman, which is an exaggerated thoracic kyphotic angle, or what we call hunchback. Okay? And the reason for the slouch in elderly patients is because you lose bone density and you lose vertebral disc, but right now we're focused on bone density. Can you see this right here? That's not supposed to be slanted. This is supposed to be flat, okay? And so as you lose bone density, and if you have 70, 80 years of compression on the vertebral column, then that kind of pushes it down. And that kyphotic angle in the thoracic area is exaggerated. Plus, in a lifetime, most of the activities that you interact with all day long, they pull you this way. There's very few that require you to stretch out this direction. Right? If I look around the room, I mean, half of you are kind of like this, you know, you're at your keyboard, you're like, right? You're just like, I'm not doing this, I'm sucking on a straw. So everything pulls us forward, and we compress down the vertebral column, and that's why you're seeing sort of these exaggerations. Now, the biggest way to treat this is prevention. Okay? Taking this 2-in-1 class, because all of you are like, Holy crap, I don't want to look like that. Okay, so what do I got to do? Okay, there's an offering plate being passed around right now. I want you to don't know, I'm just kidding. But prevention is the most important aspect of preventing or eliminating osteoporosis. Okay, so if we look further, osteoporotic bone on the right, normal bone on the left, pretty obvious. If we look at some of the facts, osteoporosis is a disease that increases the risk of fracture. It's not correct to say osteoporosis means that you have a fracture or that it causes a fracture. Osteoporosis means that you have an increased risk of fracturing the bone if you put pressure or stress on it. So in osteoporosis, the bone mineral density is reduced. It's down, it's lower than normal levels. In fact, it's defined by the World Health Organization as a decrease in bone mineral density that's 2.5 standard deviations below your peak mass. Look at where your peak mass is. How many 20-year-old females, healthy by the way, you got to self-qualify, 20-year-old females in the room, raise your hand, plus or minus 2. Come on, raise your hand, ladies. This is as good as it gets, ladies. Okay? It's downhill from here. Okay? It's so fun as a 40-year-old something to say that to 20-year-old females. But that's the truth, guys. Ladies, not guys, ladies. That is the truth. This is the peak of your bone mass. So it's more common in women after menopause because you lose that estrogen protecting factor. But it does develop in men. Okay? But it's to a lesser percentage in men because testosterone drops off at a slower rate than estrogen. Okay? So in fact, if you look at osteoporosis in patients that are over 50 years of age, 1 in 2 women have osteoporosis, and 1 in 8 men have osteoporosis. Okay? And they're predicted of those populations to have a fracture within their lifetime. There are some other risk factors for developing osteoporosis, which obviously include hormonal disorders or medication side effects. If you're on different types of steroidal or glucocorticosteroid inhibitors, you may actually lose this protective mechanism of estrogen and or testosterone. So nearly 10 million people already have it in the United States, and the number's growing. Another 18 million are predicted to have low bone mass that puts them at an increased risk of developing osteoporosis, and these numbers are also growing because our population is actually getting older. Our average age lifespan is increasing slowly over time with improvements in healthcare and with knowledge and understanding. People like you are moving on into the workplace and educating more and more patients, and we're living healthier, okay? And so we're living a little bit longer. So 80% of those with osteoporosis are women. That means 20% are men. I know, it's biology class. There's a little bit of math. So 20% of osteoporosis affects men, and 80% is actually females. This is that stat that I presented to you just a few moments ago. How do we treat it? Or how do we try to mitigate? It's not really a treatment, it's more of a mitigation. The way that we do this is, in females, we will provide replacement estrogen. Now, replacement estrogen helps to slow, in some cases, in some patients, they respond really well to estrogen replacement therapy, and the bone loss will completely stop. But some patients can't handle estrogen replacement at all. And so, if you talk with your mom or your grandma, okay, they're probably, either mom's either close to menopause or beyond it, or grandma definitely is past menopause. So they probably have had this conversation or even tried different types of estrogen replacements. And they may or may not have been successful. Okay? So some of these can be skin patches, or it's a pill that's taken orally. Or the other thing that we can do is we can actually, instead of targeting more estrogen, you target the receptor that estrogen responds to. So you don't completely lose all estrogen after menopause, ladies. It's just it goes way down really fast. But what we can do is we can actually make the receptor more sensitive. So the receptors that are found in the body on bone and on muscle are more responsive to the estrogen that you do have and that you do manufacture. And so it can help be maybe a second option if the patient doesn't handle estrogen replacement all that well. This is the only option, by the way, if this same population, right, it's like Breast Cancer Awareness Month, if this same patient had breast cancer or is at risk of breast cancer, you wouldn't want to give them an estrogen replacement, right, because that actually can aggravate the effect of breast cancer because the breast tissue is extremely sensitive to estrogen. So you might go the SERM direction, the selective estrogen receptor modulator. Third bullet point. Somebody in this audience take a stab at why the third bullet point makes sense in this conversation. Remember, you have an exam on Thursday, so now's a good time to practice. Is that a hand raise or is that a pen click? That's a pen click? Okay, that's cool.
So the body needs vitamin D, the bone specifically, in order to create a stronger bone. And the bone utilize it and store it. And so if a person who has osteoporosis has low density in bone, the more they take vitamin D, the stronger the bone can get medically.
Okay, that's pretty darn good. How does calcium fit into that story? That's the only piece that you missed. Everything you said I liked, that the body manufactures vitamin D. What structure makes the vitamin D? Or what structure is responsible for synthesizing vitamin D? The skin, the integument. Okay? And what does vitamin D do? There's a couple other hands back here. Yes, sir?
Well, vitamin D is like the very first step to making calcium.
Okay.
So if you don't have that, then you don't have the calcium to have the osteoblasts to build new and better bone.
Okay, so early vitamin D precursors later are converted to calcitonin, which is the most active form of vitamin D. And then let's say calcitonin, our most active form of vitamin D, physiologically, what does it do?
You need vitamin D to absorb calcium.
You need vitamin D to absorb calcium. So vitamin D encourages calcium uptake from the gut. So that's why if you have a patient that's only on calcium supplementation and they're not getting enough vitamin D, they're probably just putting it in and excreting it. It's never getting absorbed. Calcitonin, vitamin D, the active form, is necessary to encourage the absorption of calcium out of the diet at the level of the gut. Yeah? Sorry, calcitriol. Excuse me, calcitriol. Yes, thank you. So calcitriol is the most active form of vitamin D. I said calcitonin, my bad. Calcitriol, the most active form of vitamin D. Everything else I said was correct except for calcitriol is the most active form of vitamin D. Thanks, Tracy. So if you don't have active vitamin D, you're not going to absorb the calcium out of the gut, out of the diet. It's going to actually go right through. And then bisphosphonates. So these actually help with the inorganic component of the bone, the inorganic architecture. And so we'll supplement with bisphosphonates. Calcitonin, that's probably where I got this from. Calcitonin down here is another supplement we can deliver that's extracted from salmon. And it's a hormone, and it actually helps to slow bone loss. Right? And if you remember back to our negative feedback loop slides that I alluded to, and look at the role of parathyroid hormone and calcitonin on bone homeostasis or calcium homeostasis. And that will help answer this last bullet point of why you would supplement with calcitonin. Because in that feedback loop, calcitonin encourages more bone deposition. Right? Calcitonin is released when blood calcium levels are high, and then it puts more calcium into the bone. And that would help increase the bone density in that particular patient. So, shifting gears slightly, but sticking with bone stimulation or encouraging bone growth, the future probably is going to utilize other types of sexy technology, for lack of a better term. Okay? So, yeah, woo, Somebody's awake now. So, this is a recombinant human protein. That means that we make it in a laboratory. And it's called bone morphogenic protein. And it's called RH for recombinant, BMP2. And this company, Medtronic, has figured out a way to actually impregnate it, incorporate it into a metal device that's used as a lumbar fusion device. Why would you want bone morphogenic protein on a piece of metal that's touching the spine? Any ideas?
If it's touching the spine and it's able to morph to the spine, then it would, rather than like putting a new hip in, it would just sit there. It would actually adhere to the spine and then create a better...
Right, so if you have this bone morphogenic protein, this growth factor that's stimulating bone growth, and it's touching the bone, and it's sitting in and on the metal, it's going to encourage the bone to grow into the metal. Okay? But we could use, in the future, similar types of technology in patients. We could deliver different types of recombinant drugs in order to encourage bone growth. Okay? We could use, again, more sexy technology than just what's listed right here. So as you guys move on in your careers, you're going to see really cool things that come into clinical practice that are used in other places. So for example, one of the locations might be on hip replacements. Looking at hip replacements, can we infuse a hip replacement with a surface coating that actually have this BMP factor, this bone morphogenic protein, and encourage bone integration into our devices more readily? So I want to talk about a case, an osteoporotic case. This actually is a real case, but it's MG, the initials, is used to protect the identity of the patient. So a 70-year-old woman who fell on the dance floor at her daughter's wedding. She was unable to walk and complained of moderate pain about her left groin and thigh. Examination in the emergency department revealed good range of motion of the left hip, although it was painful, no deformity was noticed. If we take a look at her radiograph, you can actually see from the explanation, we said that she had pain about her left groin. That's this side. What side is this? Right. That's her right. What happened over here? That must have been a different wedding, apparently. Okay? So this is a 9-year-old's total right hip replacement. And now she's concerned about this side. If we continue on and we kind of rotate anterior to posterior, you can see that there between the trochanters, where the red arrowheads are highlighted, is this fracture. And so what we've done in this patient, you can see here's a different view. And this is a little bit maybe more clear because you can actually see right here the fracture. In MG, we've actually put in this device. This is obviously open or closed? Open. This is an open reduction. And this appliance goes in. You can see from a rotation, here's the fracture. It hasn't obviously healed. This is just post-operatively. But this appliance will actually stay in place in this patient. Is it compromising the medullary cavity? Well, yeah, it absolutely is. But the doctor's going to make the decision of, you know what, it's 78, and with her dance history, I'm much more comfortable leaving these devices in place. You know, she probably is going to get another 10 to 20 years max out of these devices. But I know that over the next 10 to 20 years, her bone loss is going to increase. Okay, it's going to continue. So what I want you guys to talk about amongst yourself, this is kind of an integration of this information. You know that the patient, she told you, she's on aspirin and Coumadin. Coumadin is a type of anticoagulant of the blood. People like to call them blood thinners. I hate that term. Blood's not any thinner. It just doesn't clot. And she has high blood pressure. The question, that's the background you know. The question I want to pose is, what type of gait? Gait means walking, running, jogging, dancing. Okay, that would all be gait. What kind of issues do you expect she's going to experience immediately post-operatively, maybe 6 months later? What type of dietary suggestions are you going to make? And do you have any exercise suggestions? And why did you pick those? So, Talk amongst yourselves for a minute here. Okay, how about a volunteer for our first question? Volunteer. You can be just representing spokesperson for your little group. What kind of gait issues? Immediately, maybe 6 months later. Go ahead.
Immediately, you'd probably have a difficulty walking just because you had open surgery. But as time went on, the more you walk, the more blood flow would occur, and then you'd be able to walk better. And over time, your normal walking pattern might change just because you have a new appliance in your body, but then you would just be able to walk as nothing would happen.
Okay, so very good. Early on, probably some gait issues like having challenges walking, probably a limp, probably going to be favoring the left side. Remember, the right side had a 9-year-old hip replacement, but it seems like it's pretty stable. I mean, she was boogieing on the dance floor, so I was saying bug her. Do you think that's going to be a conversation you're going to have of, you know, MG, no Macarena for a little while? Okay. Did you guys see the Zumba video of the construction workers? You guys didn't see that? Oh, you need to Google the Zumba. It's like, this is like this construction crew that does Zumba every morning before they get on the job. And it went like viral this week. I'm surprised that, I mean, you guys are so out of it. It's crazy. I'm telling you about what's happening. All right. So anyways, no Zumba, no Macarena for a little while, right? She's going to obviously need a walker, okay? Maybe 6 to 9 months later, with PT, she'll have less of a limp. She won't be favoring it as much. Now, what you know about bone health, do you want her to be walking long term? Or do you want to be like, don't move? Strap yourself into a Skylark with a remote control and zip around everywhere.
She needs to walk.
Why does she need to, oh, look at you guys, you're getting like belligerent. That's awesome. Why does she need to walk? Because it won't regenerate if it's not loaded or stressed. Whose law was that? Wolf. Nice job. First name? Julius. From? Germany. Nice. All right. Super. Okay. Now, next one. Dietary suggestions. Yes, sir.
All right. So, like, eat fruits and vegetables. Probably eat potassium because that lessens sodium on your blood pressure.
Okay, so we have to be a little worried about her blood pressure.
Yeah.
So maybe watch out for the sodium, lots of fruits and vegetables, which is good for all of us. But her GI tract's going to be a little off after surgery, right? A little constipated most likely. So, you know, she needs to watch her diet. What else? Keep going.
Did I already say potassium?
Potassium. Why potassium?
Because I believe that lessens your sodium levels on your...
Oh, okay, so watch out for her sodium levels. Okay, good. Anything else in the diet specifically you would like to see? Over here? Yes? Some calcium. Some calcium. Pretty good. Right? And if you're taking calcium, what else do you want along with it?
Vitamin D.
Vitamin D. Okay, so maybe some PT outside would be kind of a good idea, right? Out in the sunlight. Maybe not yesterday or today, but hopefully, you know, the rest of this week. All right, any exercises? What type of exercises do you like?
Walking.
Weight-bearing exercises eventually. What's over here?
No stress, like water aerobics.
low stress in the beginning. Maybe once the surgeon says she can bathe and we're not worried about the primary surgical sites, to get into the pool and do some water aerobics. Okay? Yes? Balance activities. Okay, she's got 2 broken hips essentially. One old one, one new one. Okay? She's obviously very active, so you're probably not gonna have a lot of patient motivation issues. Right? It's probably more of a, I want to hold you back just a little bit so that we don't break something else, okay? And then you can, you know, Saturday night fever all you like. Yeah, she's on Coumadin, so she'll probably be off the Coumadin until after the surgeon says she can go back on it. But you want to be careful about low risk so she doesn't fall and bleed aggressively. Wow, you guys are really into this activity. Yeah. Range of motion stuff. She's going to be stiff with that hip. Okay? All right, so I'm just trying to make this relevant to where your future is, and you'll probably see patients like MG. You're going to see other patients that aren't nearly as fun to work with. They don't want to move. They're like, you know what, just order me one of those things I see on channel 27, and I will just zoom all over the kitchen. Give me like one of those things I can reach the stuff off the counter with, right? All right. So another type of future therapy. Now, this is a publication in 2000, but this is in the literature in science journals, and these are experimental therapies. But this is actually talking about stem cells. So what I want to show you is, this is some of the fathers of tissue engineering, and what you can see here is a defect was made, right? So between the 2 screws, this is a piece of long bone in an animal model, and here is the black rectangular cutout of where the defect is. And then that defect, the control defect, was left to heal to 16 weeks. This one are mesenchymal stem cells loaded with a matrix. The matrix is a hydroxyapatite tricalcium phosphate. Do I expect you to remember all that? No. It's stem cells in a matrix. That's all you really need to know. This one has no stem cells. It just have the matrix, right? The HATCP. So matrix only you could write, stem cells plus matrix, and then empty defect. If you look at the results 16 weeks later, look, the empty defect is still trying to close. The stem cells with the matrix, that bone looks darker and denser than even the native surrounding bone. You see that? How much whiter it is? Over here, just the matrix only, it's closed in better than the control defect, but not nearly to the extent as if you incorporated stem cells. So are you going to see stem cell therapies in your patients in the future? Very likely. Very likely. Okay? All right, let's, in the last little time together, let's talk about bone health. And this is really the prevention side of things. So there's a relationship, sort of a tipping point, if you will, between bone resorption and inadequate new bone formation during remodeling and an inadequate peak bone mass when you've reached, say, your 20s. Okay? So I'm joking around when I say, you know, it's as good as it gets. The good news is, ladies, is it stays at this great level for a little while. Okay? And I'll show you some of the data. But the real time to act is actually when our children are learning about things in their pediatric years. Okay? So excessive bone resorption, what cells would be responsible for resorbing bone? Osteoclasts. What cells would be responsible for forming bone? Osteoblasts. Very good. Now, if we look at this question, the most important age range for taking action to prevent bone loss is what? 0 to 20, 21 to 40, 41 to 60, or 61 to 80? A, absolutely. As early as you possibly can. Why is that? Well, here's the graph that I was talking about. So between the ages of 0 to 20, you're growing your bone mass as an individual. And this is men and women. And then in your 20s to really to your 40s, you plateau. You don't really grow any new bone density. Now, plus or minus a little bit. And then in our 40s is where the bone loss starts to actually take place. Now, if we think about the graph of intake and age, if you're following this chart, for example, B, and you're a female, because now there's menopause on the list, this would be female's chart. At the level of bone density at level B in your 20s to your 40s, and then when menopause hits, you can see the line puts you in this high risk category. If you enter your 20s and your 40s prior to menopause at a much higher level of bone density, it's the same slope. But the reality is, by the time you're in your geriatric years, you're still in a low-risk category because you started out with more bone essentially in the bank when you began. And that's why education is so key. You see all of these energies and grants responsible for, having milk in the classroom cafeteria, in the school cafeterias, and educating our youth about sunlight and exercise and load-bearing activities. Physical education, at a young age, and getting the kids to, drop the device, get off the couch, and go kick a soccer ball is so important. So if we look at how men and women compare, you can see very quickly that men are at less of a risk, but they're not at zero risk. So women, in this conveniently colored pink line, you can see in our 20s to our 40s is where the peak mass happens. Men, it's the same thing, but men tend to have more lean body mass, more muscle tissue per size. And if you have more muscle tissue per size, that means you need denser bones to support that muscle force. Okay? So men are starting out with more bone density than women generally. And then in menopause, menopausal loss is this giant curve right here that is absent in men. It's more of a continuous slope. And so it's not correct to say that men are not at risk of osteoporosis. They're just at less risk than women. So here's the question. The average bone mass for men in their 80s. What is the average bone mass for men in their 80s, approximately, off of this graph? So this is just, can you read a chart type of graph, right? This is a standardized test. I'm just determining if all of your prerequisites were helpful. But you go 80 on this graph, you go up to the black line, because that's the line for men, and you can come over to this and you can see that 80, I'm at a parallax here, so a little bit above 1,000, but not to 1,500, so that's C. Okay? How about this one? Does it differ based upon ethnic background? There is some differences. Okay? There are differences between different ethnic groups. There are differences between men and women, different ethnic groups, and the ones that are at the greatest risk are Caucasian, petite females. You're like, why do you got to be that way? Dude, it's just the data, okay? But you think about, the educational piece in this era, okay, where there's a lot of diversity in our patient populations, and even if you're if I look out in this classroom, it's a diverse population. We have men and women, we have different ethnic backgrounds. So you can kind of appreciate that there are some that are at less risk and there are others that are at greater risk. And I'm just telling you exactly what the greatest risk category is. It's Caucasian, petite, females. Okay, so from this graph, what's the answer? B. Okay. Look at this data. This is old data, 2003, but the trends have stayed really about the same. So the scale here is not chronologically to scale. What I mean is 2 to 5 months, right, is sandwiched in here, and so 0 to 9 years of age is in this first segment, and then you go from 9 to 18 here, 19 to 50, and then 51 and beyond. So it's not scaled chronologically, but it is in order. So you can kind of see that the comparison here is between the adequate, what we call adequate intake, and what actually takes place with food and supplements. Supplements would be like vitamins or nutritional supplements in the diet. And you can kind of see that in the early ages in our young children, up until about, maybe their early teens, we do a pretty good job. And then from 9 to 18, the requirement of the amount of calcium intake in females goes up to like 1,200 milligrams a day, and our intake in females is still hovering at about 800. And this is really our problem, is our teenage population, which isn't that far away from this classroom, right? You all remember this age in your life. And so that's really where we're starting to target. Much of our education in the elementary schools is working. But what's not really working yet is junior high and high school education of dietary requirements. So how much calcium do our teens need? Right? Teenagers in the same category as those over 50. You see, you tell your teenagers, you and grandma have the same concern right now. Okay? Grandma cares about boys? What? So 1,200 milligrams. 20, right, where you are right now, 20 to 49, it's about 1,000. So it's 1,200 in this teenage population and over 50. And you have to remember that the problem with not enough vitamin D, most of us don't have enough vitamin D, is we only absorb 30% at best of the calcium that we're getting in our diet. Okay? So some other sort of sobering pieces of information. What's your favorite soda? Or Pepsi, Mr. Pibb? This is relevant. The reason I'm asking you this question is I want to show you this study. If you look at the back of this Coca-Cola can, you can see that it's got carbonated water, sucrose, coloring, phosphoric acid, and caffeine. Okay? If you look at cola consumption and bone mineral density, this was done on teenagers. These are female teenagers that were self-enrolled in the study, and you can see their bone mineral density of their femoral neck, if they had 0 soda in a week, was at about 0.89 grams per square centimeter. And if you can appreciate, as they go to, that's not 100, that's greater than 7. It's slide 100. It's greater than 7, so that's a soda a week, or soda a day. That is statistically significant. It basically drops it in a statistically significant fashion. That's not half, because look at the scale. It goes to about 0.855 from 0.89. But it's statistically significant. So the question is here, is it because something in the soda is causing bone resorption? Like, for example, phosphoric acid? Or is it because caffeine, we've seen that there's a correlation between caffeine that negatively affects the absorption capabilities of calcium? Or is it just simply, there are 3 conclusions in the study. The third one is maybe they're just drinking more soda and they're drinking less other stuff. Like they're not having as much milk or fortified orange juice and they're having soda instead. This study is our last study of today. This one's looking at the benefit of exercise. So diet is important. Stay with me, guys. I have another minute, and this is an important slide. Diet is important. There's no question. Our target population that we need to be educating are teenagers. Okay? The message is less soda, more other quality things. Okay? And then the last piece is exercise. So if you look at this data, between your right and your left arm, there is a difference in bone mineral density. There's mostly a 3 to 5% difference between your right arm and your left arm. How many of you play tennis? How many of you golf? Okay, how many play lacrosse? Okay, if you play these sports on a regular basis, you might have a larger difference between your dominant and your non-dominant arm in bone density. But what happens is, if you look, here's the 3 to 5% difference normally, And these were female tennis or squash players, racket players, okay? And if you look at when they started their training, if they started their training before puberty, the difference between their dominant and their non-dominant arm was much, much bigger. And what that tells us is, if you're loading the bone before puberty, the bone remodels even stronger and more dense. If you load the bone after puberty, you can still have a greater effect than if you did nothing, but not nearly to the extent as if we can target exercise and diet at a younger age before our young girls hit puberty. We're going to result in bone mineral densities in their 20s that are at their highest level. Does that make sense? Okay. That's the end of the material. I'll see you on Thursday for our second exam.